Between 2005 and 2009, 480,317 was the annual rate of cigarette smoking-related mortalities, and it remains the single largest preventable cause of death and disease in the United States. Many tobacco users began experimenting during their adolescence and continued into adulthood with the addiction. The Center for Disease Control reports that by the age of 18, 9 out of 10 cigarette smokers had tried smoking, and 99% first tried smoking by age 26. The daily rate of cigarette smoking initiation in the United States is more than 3,200 for youth aged 18 years or younger, with an additional 2,100 youth becoming habitual cigarette smokers. The CDC warns that if the pace of young smokers continues at this rate in the United States, 5.6 million of today's Americans younger than 18 will die early from a smoking-related illness. With these high rates of preventable tobacco-related deaths, prevention efforts naturally should begin with the youth. In general, the responsibility of public health as an organized community effort rests primarily in the hands of government. However, much like how the Minneapolis, St. Paul, and Taos Pueblo, New Mexico communities realized new partnerships and innovative approaches were needed to improve community health, so too are similar partnerships needed to develop a successful public health initiative. The evidence-based program Not on Tobacco, or Not for short, an innovative program geared to help teenagers quit smoking, was developed through a collaboration between West Virginia University Centers for Public Health Research and Training, the West Virginia State Health and Education Departments, the Coalition for Tobacco-Free West Virginia, and the American Lung Association. The goals of NOT were to determine if the program would be effective in decreased smoking in the youth, increased smoking cessation, if it proved to be sustainable across diverse settings, and to be recognized by the National Registry of Effective Programs. This program consists of 10 50-minute teen-friendly small same-sex group sessions. The groups were led by same-sex facilitators who discuss various topics such as motivation, stress management, the effects of smoking, preparing to quit, relapse prevention, dealing with peer pressure, media awareness, support networks, and healthy lifestyles. Additionally, 4 optional booster sessions were offered at the conclusion of the program. The target population for the NOT program was high school students between the ages of 14 and 19 in the United States, and from 1997 to 2002, the program was evaluated in 6 arduous studies in West Virginia, Florida, and North Carolina. The selected target population offered the opportunity to explore the following variables: socio-demographic, environmental, behavioral, and personal, current behavior relative to tobacco. The Surgeon General's 1994 report discussing the prevention of tobacco use among youth and young adults suggests that these 4 psychosocial risk factors influence the initiation of tobacco use, all of which had an impact on the effectiveness of the NOT program. The program appealed to diverse perspectives. For example, under social demographic factors, gender was addressed by making the groups gender specific with same-sex facilitators, because some things can be openly discussed in this type of setting versus mixed gender groups. The socioeconomic status of the community or county of the school locale and the type of community in which the school was located, that's rural versus suburban, was considered by the selection of the diverse Appalachian region. It seems that lower income and rural areas revealed that the rate of cessation was lower than higher income and suburban areas. Environmental factors were considered by looking at the student population size and student-teacher ratio, the geographic location, and by discussing ways of dealing with peer pressure and media awareness. Behavioral factors were observed by conducting the sessions in school settings where organic conversations about aspirations would likely take place, along with risk-taking characteristics and lifestyle factors, such as diet, sleep, and exercise. Personal factors and current behaviors relative to tobacco were also addressed via the discussions about stress and stress management, the effects of smoking, preparing to quit, relapse prevention, and support networks. Since 1999, more than 100,000 teens in 48 states have participated in the NOT program. The assumption is that approximately 1 out of every 6 participants quit smoking based on the demonstrated effectiveness of this 4-year program. Peer review by an independent group of scientists further validated the efficacy of the NOT program. It was due to this validation that the National Registry of Effective Programs included NOT in the Repository of Science-Based Programs, and the Substance Abuse and Mental Health Services Administration, SAMHSA, recognized NOT as a model program. The resulting impact of the recognition helped to make NOT more available to teenagers in need. Consequently, the external stakeholders for the NOT program include the National Registry of Effective Programs and Practices, which is NREP, SAMHSA, participating schools, and the communities in which the schools were located. The NREP is a resource used by SAMHSA to improve access to information about evidence-based programs and practices and reduce the lag time between creation of scientific knowledge and its practical application in the field. This heavily vetted tool provides the public with a reliable source of data on mental health and substance abuse interventions. The SAMHSA agency was established in 1992 by Congress, and it is part of the U.S. Department of Health and Human Services, and its mission is to reduce the impact of substance abuse and mental health in America's communities. Receiving recognition from this agency was significant, since SAMHSA's seal of approval could increase support for the program's dissemination nationwide and possibly beyond the U.S. borders. The NOT program was well funded from numerous sectors, beginning with the CDC Prevention Research Center grants, West Virginia Department of Education, National Office of American Lung Association, American Lung Association of Florida, various state tobacco initiatives, and state and local school systems. Even with the tremendous amount of support and the great deal of funding allocated for the program, there were and continue to be many others who pose a challenge to the program's effectiveness. From when the first hint of a maturing tobacco seedling peeks through the soil to the consumption of its age-dried leaves, every person who earns a living from the tobacco industry is an opponent. The tobacco farmers who engage in the growth, the manufacturers who process the plant, and the advertisers and distributors who market and move the finished product would all be concerned about the decrease in use of tobacco and tobacco-related products. And rightfully so, they should be. With cigarette use continuing to decrease in the United States, tobacco companies have increasingly gone overseas both to sell and to buy. Another group who could be viewed as adversaries are politicians. In 2011 to 2012, nearly $54 million in contributions were received from tobacco donors to state-level candidates, political parties, and ballot measure campaigns. While that might seem like a large contribution, it is significantly smaller than the $96.6 million the tobacco industry donated in the year 2005 to 2006. One industry which most might not view as an opponent to such a program would be the pharmaceutical industry. From mouth, throat, and lung cancers to cervix, colon, and rectal cancers, and everything in between, Roche Pharmaceuticals is leading the way in cancer drug treatments and related side effects medications in the world. A quick glance at this chart reveals that Roche is developing the largest number of combination therapies by a wide margin, with Merck, Bristol Myers Squibb, and Novartis following. So it can be surmised that Roche yields the highest profits from smoking-related illnesses. Matthew Herper of Forbes reports the global market for cancer drugs has hit $100 billion in annual sales and could reach $147 billion by 2018. From this angle, it is easier to view the pharmaceutical industry as opponents to the NOT program. Politics and ethics are two additional components that play significant roles in the development and implementation of the NOT program. Laws put in place can have beneficial or adverse effects on how research is conducted and its outcome. Sometimes the laws reflect the ethical culture of the community, while other times the relationship between the political culture and the ethical culture of the community are like oil and water. Most people learn ethical norms as a child from parents, teachers, or clergy, but morality evolves as the individual matures. Typically, societies govern its citizens' behaviors by the enforcement of laws, but ethical norms tend to be broader and more informal than laws. However, ethics and laws are vastly different, meaning that an action may be legal but unethical, or illegal but ethical. When considering research, a code of ethics is important, so much so that many professional associations, government agencies, and universities have implemented specific codes of ethics. Some of the ethical concerns in the development and delivery of the KNOT program were parental involvement, the cognitive ability of teens to consent, confidentiality, and challenges that arise in the group settings. Recognized high-risk groups such as youth from less educated, impoverished rural areas were of greater concern. Teens from these groups tend to be ones that start smoking earlier, have a higher smoking rate, and have higher risk for developing smoking-related mortality and morbidity later in life than their non-rural counterparts. Intervention with this high-risk group is significant because it provides an opportunity to address current disparities in risky behaviors as well as health disparities in tobacco-related chronic disease. And since the sale of cigarettes to a minor is against the law, teens may be reluctant to participate due to a fear of repercussions for the purchase of these illegal cigarettes. Many teens also may not readily reveal their smoking status to their parents, so it is important to protect the teen's confidentiality. It would be feasible to use a method to record the participants' data which does not display any personal identifiers. Within the group settings, personal information is revealed, and while the participants are asked to keep all conversations which take place within the group setting confidential, it is inevitable that there will be some leaks. It is close to impossible to ensure complete confidentiality within such a setting. Group settings also expose naive participants to individuals experienced in manipulating the system or people to obtain cigarettes illegally. So it is essential to have the same gender groups facilitated by a same-sex facilitator to eliminate challenging situations which could take place in a mixed gender group. It is also beneficial to have a facilitator who can steer conversations that might lead to undesired behaviors in a positive direction. There were 2 studies performed which compared teen smokers who participated in either KNOT or a brief intervention or BI smoking cessation program. The brief intervention program consisted of a 10 to 15 minute presentation of scripted advice and a self-help brochure. The first study was conducted with the Appalachian teens in North Carolina and West Virginia. 3 months after the intervention, 8.1% of KNOT participants reported continued smoking cessation compared to 2.2% of BI participants. In North Carolina, the proportion of students who reportedly had maintained their quit status after 15 months post-intervention was higher in the KNOT program than in the BI group program, at a rate of 9.8% versus 1.6%. The second study, which was conducted in Florida, yielded an even higher percentage of KNOT participants who reported smoking cessation 5 months after the intervention, at a rate of 21.7% compared to 12.6% of BI participants. Furthermore, KNOT explored the students' readiness to quit smoking by employing the trans-theoretical model, with pre-contemplators being those who were not planning to quit in the next 6 months, contemplators with those who are planning to quit in the next 6 months, and preparers for those planning to quit in the next 30 days. So by getting the community involved as stakeholders early on in the process, a good program can only become an even better program if it's sustainable. So it is very essential to have community buy-in. A few ways to secure this is to start by doing some research and observation on the schools, surrounding neighborhoods, the pre-existing partnerships established by the school, and the previously mentioned psychosocial risk factors that influence the initiation of tobacco use. It would be beneficial if some of the teens who are willing to engage family to join them in their cessation journey, especially family members who smoke. By limiting the amount of contact to tobacco products teens encounter at home and at school will provide an environment better suited for them to quit smoking and stay quit. Additionally, with family members who work towards quitting with the teen, it can provide an atmosphere conducive to their attempts at quitting, and they each can serve as a support for the other. Collaborate with community partners to combine smoking cessation programs with local healthy lifestyle programs activities. Meg Riordan with Campaign for Tobacco-Free Kids suggests that community programs are essential to reducing the tobacco use and in fact are the foundation of any statewide tobacco control program. State funding for tobacco control enables local entities, community organizers, partners, businesses, and schools to forge a strong, diverse coalition with the ability to reach people where they live, work, play, learn, and worship, to influence social norms in regards to tobacco use. These community coalitions can also play a key role in addressing the tobacco use while educating the general public and media about the social, financial, and health toll of tobacco use. If possible, gear the data of this information towards the targeted community. Danny McGoldrick with Campaign for Tobacco-Free Kids speaks out about the Camel Cigarette Company's marketing tactics aimed at women and girls, stating, "This is some of the most aggressive marketing we've seen to this target in over a decade. A powerful means to counter these persuasive marketing devices is to implement counter tobacco industry intensive campaigns, delivering health lifestyles communication campaigns, promoting smoking cessation programs, and sharing the consequences of tobacco use via media and local community events will go far in changing the social norms in relation to tobacco use. Counter marketing efforts should target both youth and adults with prevention and cessation messages and should have sufficient reach, frequency, and duration to be successful. Any restrictions placed on the strategies used in these efforts will only hamper the effectiveness." The reasons why NOT was successful was because the researchers used reliable and valid measures and had set procedures for training, implementation, and evaluation. There are several factors which contributed to the need of the NOT program. For example, increased adolescent smoking rates, and while these rates have begun to level off, in the year 2000, 31.4% of high school seniors had smoked in the past 30 days, and 20.6% reported almost smoking daily. Also, since the cigarette smoking is the leading preventable cause of morbidity and mortality, it's not hard to see why the cessation program would be beneficial. Additionally, recent regulatory efforts have come to light per the National Institutes of Health guidelines which mandate pediatric inclusion studies. The development and implementation of more teen and family-focused programs geared towards the prevention of unhealthy behaviors would be helpful in minimizing many adverse health outcomes later in life.